Hello everyone, and welcome to the next video in our series on human microbiome and dysbiosis in clinical disease. Today we're going to focus on the dysbiosis bilocation series. I started that previously with mouth, then number 2 was sinus and respiratory tract. Today we're going to focus on the genitourinary tract and then move pretty quickly into tissue and blood dysbiosis, then skin, environmental. Gastrointestinal dysbiosis really deserves to be its own topic. And then I'll discuss the gut-brain connection before reviewing for the final exam for the course. As you all know, the information is protected by copyright and trademarks, as we've discussed previously. I have worked as a consultant researcher and lecturer for Biotics Research Corporation. Some of the treatments that I discuss, especially when we're talking about pharmaceutical drugs, might be considered off-label or unapproved by the U.S. FDA, so prescribing physicians will need to determine the appropriateness of drug prescribing per patient and per condition. So you've seen this overview or summary slide previously. Again, what I want us to all appreciate is that when we talk about dysbiosis, what we're really talking about is some combination of multifocal polydysbiosis. People rarely have dysbiosis in one location with one microorganism, even though that does happen. That's usually not the case that we're looking at in clinical practice. So we need to be able to assess and appreciate the contributions from different locations and by different microorganisms at the same time in the same patient, whether they have one disease or multiple diseases, especially the inflammatory and autoimmune conditions that we'll talk about through some cases later today. The location subtypes are listed. I've also discussed previously some problematic microbes, and we've already reviewed the molecular mechanisms. Moving on now here, again, I provide an overview of the structured approach, discussing different locations, how each of those locations can contribute different combinations of microbial molecules based on the receipt of those different microbial molecules in different quantities and different patterns. Then we see different pathophysiologic responses, and that leads ultimately to different clinical prototypes that we have to deal with in clinical practice. Again, you'll notice that the multifocal polydysbiosis component is only one component of the overall protocol, which I call the functional inflammology protocol, remembered by the FIND-SEX acronym. That's F for food, I for infections and dysbiosis, N for nutritional immunomodulation, D for dysmetabolism and dysfunctional mitochondria, S for style of living, sociology, sleep, stress, special considerations such as surgery, E for endocrine, and X for xenobiotic load and xenobiotic detoxification. Again, as I've said many times before, now dysbiosis is a relationship of non-acute, non-infectious host microorganism interaction that adversely affects the human host, and obviously we've already reviewed multiple mechanisms by which that can occur. Let's apply an accurate perception of dysbiosis to clinical applications by naming at least 3 components of anti-dysbiosis treatment. By now, you appreciate that those are antimicrobial, immunotolerogenic, and immunodefensive or immunonutrition. So reviewing again, starting with number 1, we can kill off the bad microbes. We can add more good microbes. For number 2, we can promote immune tolerance to the microbes that are present. And number 3, we can support optimal immune defense against the microbes that are present, because obviously the immune system should be defending us from microbial overgrowth, which eventually promotes the development of inflammatory disease. We've introduced each of the locations, and what we're doing right now is detailing each of these major locations. I've shown you several cases already, and we'll go through a few more today. Here's a recent case in my clinical practice of gastrointestinal growth of Staphylococcus aureus. You can see that this patient has gastrointestinal colonization with Staphylococcus aureus. I never consider Staphylococcus aureus to be normal gastrointestinal flora, because we all know that Staphylococcus aureus produces a superantigen that acts like endotoxin, even though it's a gram-positive bacteria. We also know that Staphylococcus aureus produces an exotoxin, which actually impairs the clearance of endotoxin from gram-negative bacteria, and therefore leads to an exacerbated inflammatory response because that endotoxin isn't properly cleared by the immune system, especially within the liver. So anytime we look at Staphylococcus aureus, we need to think of it in terms of its gram-positive properties, that is the superantigen and the exotoxin, but we need to think of Staphylococcus aureus as also exacerbating inflammation caused by gram-negative bacteria. In this case, this patient also has Citrobacter fruendii. So the combination of this gram-positive bacteria with gram-negative bacteria is going to produce an additive or synergistic inflammatory response. Again, what we're doing now is working our way pretty much head to toe, starting with orodental, then sinorespiratory. Genitourinary is our topic for right now. Then I'll discuss tissue, blood, and parenchymal dysbiosis, then cutaneous, environmental, endomicrobial, and then ultimately gastrointestinal as well. So we already talked about sinorespiratory dysbiosis, today genitourinary, then following this presentation, tissue, blood, and parenchymal dysbiosis, again cutaneous, environmental, and a little bit of conversation about endomicrobial, which is microbes within microbes, such as bacteriophage viruses that infect the gastrointestinal flora. So you can actually have viruses within bacteria, and that can be of potential clinical consequence, especially for inflammatory bowel disease. I showed you this image previously. I call this dysbiosis paradigm shift number 1. We know that dysbiosis causes mucosal irritation and inflammation that increases the absorption of those microbial antigens. And of course, you can see what we're doing here is developing a vicious cycle where dysbiosis causes the absorption of more microbial antigens through tissue irritation. That leads to systemic inflammation, which can also alter the local environment to promote more dysbiosis and, of course, then more antigen absorption. And so what we see with patients is that they really do enter into a very complex and self-reinforcing vicious cycle. And so we have to address as many components as possible. For example, we address the dysbiosis, but we also have to promote anti-inflammatory pathways, and we also have to promote tissue healing of the mucosa so that we can basically overhaul and overpower this self-reinforcing vicious cycle. So the clinical implication of this diagram is that we need to be active in several different locations at the same time. For example, using antimicrobials, using good probiotics to support the growth of beneficial bacteria, also helping support the immune system, providing anti-inflammatory nutrients and botanicals, and also helping to support the mucosal integrity by using certain nutrients like vitamin A, vitamin D, zinc, and glutamine, for example, to again break this vicious cycle of dysbiosis, tissue damage, absorption of antigens and inflammagens, and ongoing inflammation and dysbiosis. We have to break the cycle, and we do that by addressing each component of the cycle as completely as possible. So let's take another look at this same diagram by focusing in on the clinical actions that we can take to address each of the components, which I just started to review, but I want to review in a slightly different diagram here. So for example, here we're looking at the same diagram, but what I'm going to do is help you focus in on the clinical action points, we might say, by demonstrating them here. For example, the immunosuppression that must precede dysbiosis, that's addressed through immunorestoration. That's certain nutrients like vitamin A, vitamin D, and zinc. We can use antibiotics, we can use probiotics to help restore microbial balance. Then for the inflammatory response, which is a hyperinflammatory response, we of course can use anti-inflammatory diet and nutritional vitamin and botanical protocols. And to address the mucosal damage and the increased absorption of these inflammagens, we can use nutrients such as glutamine, zinc, vitamin A, vitamin D, folic acid in the form of either folinic acid or methylfolate, CoQ10, and bovine colostrum or whey protein isolate. All of these have been shown in clinical studies with humans to help promote the repair of mucosal tissues. So we can use these nutrients as a mucosal repair protocol, so to speak, and that's actually part of our overall strategy for addressing dysbiosis in numerous locations. So here we are now with dysbiosis paradigm shift number 3. Number 1 was appreciating the complexity. Number 2 was addressing the complexity. And here with number 3, I want to talk specifically about how we address the microbes. Understanding dysbiosis as a relationship takes much of the focus off of the microbe. Therefore, the pressure is taken off of identification and elimination of the offending microbe with the following caveats. Number 1, sometimes identifying and targeting the specific microbe can produce some pretty amazing results. This is what I call the infectious disease approach. Sometimes it's virtually miraculous. Other times it basically does nothing. Number two, let's talk about what we can do to make that approach better. So let's call this the infectious disease approach, and then let's talk about what we can do to enhance the effectiveness of that. This is kind of an integrative medicine approach that I'm talking about here. Even when you're going to identify and treat specifically, you still need to do the components of immunorestoration, anti-inflammation, and mucosal repair. One of the major points that I've been making throughout this program is that sometimes immunorestoration, anti-inflammation, and mucosal repair is itself sufficient, and then you don't have to do the identification and the use of specific antibiotics to eradicate what appears to be a specific microbe causing the dysbiotic response. So again, what I'm trying to do is outline the differences between these two approaches and emphasize approach number two, but still give us all permission to use approach number one when approach number two doesn't provide us the results that we want. So let's work on supporting immunorestoration, anti-inflammation, mucosal repair. Let's do that on day one. Then if the patient's not better in about a month or two, then we can move to the infectious disease approach and look for specific results on specific tests, and then address those test results that have identified specific microbes by using specific interventions. Whether that happens to be a botanical or a nutrient or a drug, we can leave that to the decision at the time. But let's start with the foundational approach. Immunorestoration, anti-inflammation, microbial balance through the use of botanical antimicrobials, for example, and probiotics, mucosal repair, and then fall back on the infectious disease approach when we need to do that if we don't get the results that we want. And again, as I've mentioned in the case reports in the book, I've seen some absolutely tremendous clinical responses just by using immunorestoration, anti-inflammation, mucosal repair, and some botanical antimicrobials along with probiotics. I've seen that absolutely cure people of diseases they've had for decades prior. So that's why I'm emphasizing that particular approach. However, I'm also leaving space for the need to identify these microbes specifically and treat them specifically with drugs because, yes, that also does occur in clinical practice. I outlined what I call dysbiosis paradigm shift number 4 on this page, and this is a little bit too wordy for me to spend my time on right now. I've gone through it previously. You're welcome to pause the video and take a look at this. I'm going to decide to keep moving forward so we can maintain some momentum for today's topics. Today, we're going to talk about the genitourinary tract, and again, that'll be followed very shortly by tissue, blood, parenchyma, cutaneous, environmental, and then I've got a whole separate presentation on gastrointestinal dysbiosis because the gastrointestinal component, due to its sheer quantity and its clinical implications, etc., really needs its own presentation. So I'm not going to cover that in the same format as I'm covering each of these other locations because really the gastrointestinal tract is so massive and carries so many potential disease associations and clinical implications that we really need about an hour at least just to cover GI dysbiosis. So what I'm going to focus on as we go through these clinical locations and topics is what I call essentials and accessories. I want to make sure that you get the essential core information, and then we'll accessorize that core information with some extra information just to provide perspective, context, and hopefully a deeper level of mastery. So now we're going to dive into the topic of genitourinary dysbiosis. The classic example and disease association is reactive arthritis, classically triggered by a urinary tract infection, also can be triggered by a gastrointestinal infection. Reactive arthritis is so well established that, in my opinion, I think we'll all agree that no citations are really necessary beyond a quick description. Reactive arthritis is infection-associated arthritis, so the doctor has to have identified the causative or triggering inflammatory response via a microbial infection. Rheumatoid arthritis and ankylosing spondylitis also have tight associations with genitourinary dysbiosis, as I will discuss here through some cases and a quick review of the research. So when we're looking at genitourinary dysbiosis, okay, so let's look at a clinical situation here. Let's say that you've got a patient with psoriasis or rheumatoid arthritis, or as I exemplify here, ankylosing spondylitis. Let's say that this patient's been in your office now for a month or two. You've done the foundational work. You've cleaned up the diet. You've done anti-inflammatory nutrients and botanicals. You've used some probiotics. Maybe even you've used oregano oil or berberine for an overall gastrointestinal antimicrobial or eubiosis program, we might call it. Let's say that you've done some immunorestoration, you've done some immunotolerance work, and they're still not responding, and now you're concerned that you want to go look at each location and identify if that location has a specific offending trigger, microbial trigger that's contributing to this disease. And I'll give you an example from my clinical practice, a patient who I just consulted with last week, actually. What I discovered with this patient through his initial history is that he had a history of multiple sexually transmitted diseases. So, of course, that brings our focus into the genitourinary tract because that could be the location of a potential trigger for his rheumatoid arthritis, which I consider to be a variant of reactive arthritis. So let's look at some of the tests that we could do here. We could do a urine culture. We could do a microscopic exam. That's typically not going to give us data about specific microbes. So we want to do a urine culture. I'll show you some results on one of those tests in just a moment. We can also do serologic testing for chlamydia, for example. In the patient's case who I just mentioned, the 45-year-old man with rheumatoid arthritis, we tested him for chlamydia due to his history of sexually transmitted diseases. His results came back normal. We could do a DNA probe or a gonorrhea and chlamydia culture. We could also do microscopic microbiologic assessment visualization culture of, for example, urethral swab in men and women. We can swab and do microscopic and culture exams on vaginal secretions or vaginal swab in women. And we can also do the same tests on expressed prostatic secretions following so-called prostate massage. So if you've ever done a prostate massage, or if you've ever, in the case of men, if you've ever received a prostate massage, you know that prostate massage is the greatest euphemism of all time because it is not a massage. It is usually quite uncomfortable, if not outright painful. So by performing so-called prostatic massage, what happens is those prostatic secretions are expressed through the urethra, and you can actually gain insight into what's going on within the prostate in ways that you wouldn't catch just by doing a urine culture, for example, or by doing a urethral swab. You get more data from what's going on inside the prostate. Cases of reactive arthritis due to infectious prostatitis, I believe, have been published. So beyond those very basic and common clinical assessments, you can also look to the research to identify other testing methodologies that may become available commercially. Sometimes these are not available in clinical practice. Sometimes they become available, so that's why we're going to review them. I'll show you what's been done in some of the research. Sometimes those become clinically available over time, even though at the outset they are not available. Let's also talk about treatment considerations where we have varying levels of evidence. Obviously, we can use antimicrobial drugs. So if you get a patient who has an identified urinary tract infection or urinary tract dysbiosis, if you identify the microbe, you can, of course, try to kill it off by using various drugs. Whether that is, for example, Cipro used to be one of our favorite drugs, but now Cipro is so tightly associated with tendinopathy and tendon rupture that we tend to not use it as much. It's also associated with aortic aneurysms. That's another reason why we're steering clear of using Cipro, even though for a while it was certainly our first choice drug for urinary tract infections. But we have a lot of different pharmaceutical drugs that we can use for urinary tract infections, especially once we've identified the causative microbe, as we might call it. Again, we can always use immunorestorative treatments such as zinc, vitamin A, vitamin D, vitamin C, for example, glutamine, to help restore that mucosal integrity, to help restore immune function so the immune system does its job of killing off these microbes and the mucosal surface does its job of rejecting these inflammatory microbial molecules, because it's the molecules that trigger the inflammation. It's not the microbes themselves. Microbes themselves are only perceived by the immune system in the form of those respective molecules. So if we can block the absorption of those molecules by strengthening mucosal tissues, then theoretically and clinically, we can derive an anti-inflammatory effect from that simply by building better mucosal defenses. Also, tolerogenic, we can support immune tolerance so that the immune system is not overreacting to otherwise benign microbes. The clinical validity of this immunotolerogenic effect has been validated with the use of vitamin A and especially the use of vitamin D in patients with lupus. So what started out, when I first wrote this back in 2012, what started out as a concept now has been clinically validated. So this is something that we can definitely use. Also, as I'm sure you've already appreciated, a lot of the nutrients that are immunotolerogenic are also immunorestorative. Again, vitamin A and vitamin D, for example, those both promote immune tolerance and immune restoration. So we get two benefits out of that. And that, of course, is typical of nutritional therapy. We get collateral benefits rather than side effects. Let's look now at a classic article by two leaders in the field. This is published in Clinical and Developmental Immunology, March 2006. They assert here that rheumatoid arthritis is an autoimmune disease triggered by Proteus urinary tract infection. And I'll just read to you the part that I highlighted. Extensive evidence based on results of various microbial, immunological, and molecular studies from different parts of the world shows that a strong link exists between Proteus mirabilis microbes and rheumatoid arthritis. Proteus mirabilis can also be pronounced Proteus mirabilis. We propose that subclinical Proteus urinary tract infections are the main triggering factors, and that the presence of molecular mimicry and cross-reactivity between these bacteria and rheumatoid arthritis targeted tissue antigens assists in the perpetuation of the disease process through production of cytopathic autoantibodies. Now let's go on to the next paragraph, and you'll see some of the treatments that they recommend. Patients with rheumatoid arthritis, especially during the early stages of the disease, could benefit from Proteus antibacterial measures involving the use of antibiotics, vegetarian diets, high intake of water and fruit juices, such as cranberry juice, in addition to the currently employed treatments. Of course, they had to add that last phrase just to be politically correct. Let's look at what they're talking about here. They're suggesting, through very strong clinical and experimental evidence, that Proteus mirabilis or Proteus mirabilis is one of the triggers of rheumatoid arthritis. The microbe exists within the genitourinary tract and can therefore be addressed by antibacterial measures, not only antibiotics, but also dietary change, high intake of water to flush the bacteria out, also fruit juices such as cranberry juice to reduce the total microbial load within the genitourinary tract, and obviously these patients can still receive anti-inflammatory drugs as needed. So this is one of many, many citations supporting the use of a multi-component treatment approach to addressing genitourinary dysbiosis in patients who have inflammatory and autoimmune disease. Let's take a look now at a clinical case from my practice. This is a 34-year-old man who presented for consultation on possible psoriatic arthritis. I found him to have conjugate seropositivity for rheumatoid arthritis, so he definitely had rheumatoid arthritis. He definitely had psoriasis. He also had thyroiditis. So this young man has 3 autoimmune diseases at the same time. So I have many laboratory results on this patient. What we're looking at here towards the bottom of the page are antibody titers against specific microbes. In this case, he came back positive with a 1 to 80 titer for anti-Proteus antibodies. So that would support, and that would be consistent with the research that we looked at on the previous page, that Proteus is connected with rheumatoid arthritis. And as I state here in the text box, Proteus mirabilis is definitely associated with rheumatoid arthritis. Proteus vulgaris also perhaps more strongly associated with psoriasis. One of my favorite publications here, this publication is now